Hello everyone. Welcome back to Dr. Tristan Anesthesia Tutorials. I am Dr. Tristan, and we are going to be concluding our series of talks on pediatric neuroanesthesia today. We've got quite a comprehensive tutorial here for you where we're going to talk about common neurosurgical conditions in children and common neurosurgical procedures in children and an anesthetic approach to these. So I hope you guys have been enjoying the series that we've done on cardiacs and now on neuro. We're going to be moving to neonates tomorrow and then carrying on with pediatric anesthesia topics next week. Just to give you guys an update, so on YouTube now, for free, you will have access to roughly the first sort of 30 minutes or so of this talk, and then it will come to an end and you will be directed to Patreon. Please go to patreon.com/Dr. Tristan Anesthesia Tutorials, and you can pick the subscription option that's relevant for you, where you get anywhere from 8 tutorials a month all the way up to 12 tutorials with show notes, exam assistance, etc., and so much more. So please go look at Patreon and please subscribe so that you can have access to the channel. Just remember that I'm not trying to become a millionaire out of this. It costs me a lot of money to maintain this podcast, to use the various apps, the camera equipment, my time, etc. So I really appreciate your support. And then please like, share, and subscribe everywhere else. And so that's it. And then just remember that this is not medical advice. Please speak to your local doctors if you have any medical questions. And please speak to your local examiners, your local consultants, and specialists for any exam-related questions. And follow your local guidelines, please. And then finally, guys, just remember, please give me the credit if you're going to share any of the information from Dr. Tristan Anesthesia Tutorials. So let's get started, and we will just have a short message from our sponsor, Nova Anesthetic Practice Management. So today we're going to go through a comprehensive pediatric neuroanesthesia approach. We're going to talk about the challenges, the procedures, and the various outcomes that are relevant to the pediatric neuroanesthetist. And I hope that you guys will find this an important and comprehensive approach. So what are we going to talk about? We're going to talk about the unique challenges in pediatric neuroanesthesia. These are conditions where you are going to be operating on children who are potentially neonates, with congenital abnormalities, children that have had multiple surgeries, children that are small blood volume, limited physiological reserve, who may have significant deficits. They may have significant sensory and emotional challenges. They may have large tumors, etc. So it can be an incredibly challenging, but I find it incredibly rewarding part of my practice. So what we're going to focus on today is we're going to look at common pediatric neurosurgical conditions, typical presentations, and then potential complications. And then we're going to just go through some evidence-based anesthetic management strategies so that we can make sure that we have good outcomes in the pediatric population. And then I think we just need to take a minute to talk about and focus on the need for specialist care and for specialized centers of care. So what I mean by that is that, a lot of big pediatric neurosurgical procedures, cardiac, transplant, etc., these are not things that should be done by part-time pediatric surgeons or part-time pediatric anesthetists. You need peds intensivists, and you need a really sort of big infrastructure around you when you're doing a major surgery like this. And then I'm going to give you some advice and tips on how to optimize outcomes in pediatric neuroanesthesia. So what are the most sort of common neurosurgical conditions? I think the first one that we're all pretty familiar with is hydrocephalus. which is an accumulation of CSF within the ventricles, and inevitably it leads to a raised intracranial pressure. Now, I'm sure most of you or all of you are aware, that until the sutures of the skull bones fuse and the fontanelles close in a newborn and an infant, which can take up to 9 to sort of 12 months, their heads can get very, very large. And in Africa, in South Africa, in resource limited settings, I've seen images in India, some parts of China, Pakistan, it happens, sub-Saharan Africa, you get massive hydrocephalus with huge heads. And that's because so much fluid accumulates and it stops those sutures from closing. And so the skin just sort of accommodates this very, very large volume. So the most common causes of hydrocephalus are congenital issues with the aqueduct, so congenital aqueduct stenosis, Chiari malformations. And then the most common acquired cause, and probably the most common cause, is an interventricular hemorrhage and meningitis causing hydrocephalus and obstructive hydrocephalus. And those will be by far the sort of most common causes of hydrocephalus that we will see. Now, not all kids need immediate surgical intervention. Some present and need immediate intervention. They present with signs of raised intracranial pressure, of meningism, they may have a reduced level of consciousness, seizures, etc. So initially symptoms sort of start off as irritability, a bit of vomiting, difficulty feeding, and then it will slowly progress to persistent vomiting, to changes in level of consciousness, to seizures, and then, very severe circumstances, we see what's called sort of sunsetting of the eyes, and nystagmus and all of those sort of things. So as the raised intracranial pressure gets worse, so the symptoms will progress. So what are the treatment options? Well, essentially, we've always kind of done VP shunts. So that stands for a ventriculoperitoneal shunt, whereby the one end of the catheter is placed in the ventricle, it's tunneled under the skin, down the neck, and it's placed into the peritoneal cavity, where there is a one-way valve, a pressure release, a filter, etc., a siphon, and it allows CSF, as the pressure builds up, it triggers the valve to open and it allows one-way drainage. You do get ventricular atrial shunts, whereby you can place the fluid directly into the atrium. Not that I've ever seen one of those. But now what can be done as a curative procedure is a third ventriculostomy, or an endoscopic third ventriculostomy. So what that is a procedure whereby if they have a congenital narrowing of the aqueduct or Chiari malformation, they can then go in and they can actually open up that third ventricle, and they can open up that aqueduct and allow for CSF drainage. And remember, the critical thing with hydrocephalus and with the placement of a VP shunt or of a endoscopic third ventriculostomy is that early intervention is key, because without that early intervention, you get loss of brain tissue, you get a buildup of raised intracranial pressure, and you end up having profoundly poor neurological outcomes, unfortunately, for these children. So the next issue that we're going to talk about is brain tumors in children, something that I deal with quite often with the neurosurgeon that I work with. Pediatric brain tumors are the most common solid tumors in children, unfortunately. So it's quite sad, but if a child is going to have a solid organ tumor, it's likely to be in the brain, unfortunately. And these include medulloblastomas, astrocytomas, craniopharyngiomas, ependymomas, and based on what type of tumor it is, what type of tissue it is, it will dictate the severity, the prognosis, the aggressiveness of the tumor. whether surgical treatment alone is adequate, whether they will need chemo and radiation, and that will be managed in conjunction with the neurosurgeon, the pediatrician, and the pediatric oncologist. Remember, posterior fossa tumors are an important issue in children, and it's something that we're going to discuss in detail during the tutorial today. And especially medulloblastomas in the posterior fossa, but posterior fossa tumors can account for over half of all pediatric brain tumors. And the resection of these tumors can be incredibly complex. And I will tell the story just briefly of a patient that I anesthetized for posterior fossa surgery, whereby we had to do two 12-hour debulking surgical procedures with two 12-hour anesthetics to try and maintain the cardio stability and the neurostability of the child in order to resect as much of the tumor as we could, because the tumor was not suitable for chemo or radiation. And through a brilliant multidisciplinary team with the hands of a skilled surgeon and with meticulous care to the anesthetic from my part, we achieved great success for that child. And so posterior fossa tumors can be scary, they can be difficult, they can be long procedures, but they can be incredibly, incredibly rewarding. So if we look at other tumors that are important, surgically, these tumors are resected when they have got a significant mass effect, which means that they are displacing normal brain tissue, causing midline shift and raised intracranial pressure. We operate when there is obstructive hydrocephalus, or in rare occasions when there is a need for a biopsy. And depending on the type of tumor, depending on where it is, and depending on whether it's a full resection or a biopsy, it requires meticulous planning and attention to detail to address these underlying issues safely. And, basically, if you look at sort of the anesthetic management issues, we need to consider the relationship between the anesthetic and the intracranial pressure. We need to maintain cerebral blood flow. We need to try and reduce intracranial pressure. We need to keep up with bleeding, and bleeding from brain tumors in children can be swift, rapid, and catastrophic. We need good communication. We need to consider, as we have in scoliosis surgery, that we may be doing neuromonitoring, so that necessitates a total intravenous anesthetic without the use of volatiles or without the use of muscle relaxants. So, there really are very important anesthetic challenges, and a good anesthetic in these cases can really, really make a huge difference in terms of the child's outcome. And if we just focus in specifically for a few seconds on medulloblastoma, and this, as I say, located in the posterior fossa, is a common brain tumor, and we often need to address the need to have a complete resection. As I mentioned to you in the story, sort of brief anecdote that I gave you, you need to get 100% resection, otherwise they just grow back, and you need to address the obstructive hydrocephalus that these tumors often cause. So that's anesthesia for brain tumors, or sort of pediatric brain tumors. As we move along, the next condition that we're going to talk about is epilepsy and craniosyndostosis. So in children, there are some surgical options for intractable epilepsy, and this may be things such as a focal resection of an epileptogenic focus. It could be corpus calostomy or vagus nerve stimulation. And for intractable seizures, the use of these surgical procedures can be incredibly helpful and can reduce seizures in up to 60% of patients. To be honest, not something that I've much experience with in children. I'm not aware of how much we're doing of this in South Africa, but in adults, obviously, I've experienced the biggest issue with these is that these are long procedures often, And in some of them, you might need to consider awake craniotomy, which is an anesthetic technique and surgery that we'll talk about in more detail in the future. What I'm going to focus and spend a little bit more time on is the condition known as craniosynostosis. And craniosynostosis is basically where there is premature fusion of the sutures in the head. And what happens is the head gets very misshapen. It can be shrunken, it can be egg-shaped, it can be flat on the sides, So not only are there cosmetic issues, but the bigger issue is that these sutures closing with the fontanelle closing means that you've got a fixed brain space so that the brain cannot grow effectively as the child grows. And so you've got the risk of severe intellectual delay, obstructive hydrocephalus, and raised intracranial pressure. So in terms of craniosynostosis surgery, what does the surgeon do? Well, basically, it is a cosmetic correction and prevention of neurological complications. And the child's scalp is reflected back. The bones are removed of the skull. The sutures are broken open, and the bone is placed with space in between it in the correct shape on a sort of framework, a mesh kind of framework that the bone is screwed onto. And that normal shape with then spaces between the bones allows the head and the brain to grow to normal size, and then those sutures fuse at a normal age and allow normal head development, as we said, both for cosmetic and neurological purposes. The biggest issue with these surgeries is that these patients bleed. If you imagine scalping an entire skull of a child, the blood loss can be spectacular. It's ideally performed also before 12 months of age. So you've got a small child with limited physiological reserve. But the earlier we intervene, the earlier we can ensure optimal neurological outcomes and optimal cosmetic outcomes. The biggest anesthetic considerations, as I've said here, is that we need to be aware of the risk of catastrophic bleeding, rapid bleeding, and the entire head and neck of the child is exposed for the entire surgery. Where do infants lose all of their heat from? Their heads. So they get cold. So you need to have invasive lines, you need to have multiple IV lines, you need to have a warm fluid, warm blanket, warm theatre, all of those things. And you need to keep up with fluid loss meticulously. You need a surgeon who uses good diathermy technique, bone wax, all of those things, and who is as quick as possible. And the goals, as we've said, are to, from an anesthetic point of view, maintain hemodynamic stability, maintain neurological function with brain perfusion, make sure you don't get any spikes in intracranial pressure, prevent any seizures, etc. And for the surgeons, you want to get optimal cosmetic and neurological outcomes by ensuring a normal head size and normal growth of the child's head. So they can be very challenging surgeries, but I love being a part of them because they're incredibly rewarding. If we then look at other common neurosurgical conditions, just to mention a few, traumatic brain injuries, unfortunately, TBI in children is a huge issue, especially where I live and work in South Africa. We have high rates of pedestrian vehicle accidents, motor vehicle accidents, gender-based violence, abuse of women and children, drugs, alcohol, gang violence, you name it. So traumatic brain injuries in children is a huge issue, and it's one of the leading causes of death amongst young children when you look at trauma around the world. And we need to be able to manage these children effectively with traumatic brain injuries. And often interventions will include decompressive craniotomies and evacuation of subdural or subarachnoid hemorrhages, and procedures to reduce raised intracranial pressure. And essentially the most important things when it comes to traumatic brain injuries And when we discuss this in more detail in adults and we look at the Brain Trauma Foundation guidelines, what's critical is to maintain normal hemodynamic parameters. So you need to keep that blood pressure of the child normal. You need to bring the heart rate down. You need to keep the hemoglobin normal. Don't let them get cold, but don't overwarm them and all of those things. So just good, solid ACLS, PALS, pediatric advanced life support principles is key to help to manage these kids and reduce complications. And we must balance the severity of their injuries and keeping them alive versus trying to be as neuroprotective as possible. And that can be a challenge. The next thing that I've been a part of a lot and that we need to just consider briefly is neural tube defects. So what we call spina bifida, meningomyelocele or myelomeningocele, depending on which country you're from. Most commonly caused by folate deficiencies, congenital abnormalities, syndromic or chromosomal abnormalities, or exposure to other toxins and teratogens during early pregnancy. Basically, you get failure of the neural tube to fully fuse at the back to then get covered by bone, ligament, muscle, skin, etc. And in the worst situation, you get a full meningomyelocele where the lower part of the spinal cord, the so-called cauda equina, is born outside in a sac and is non-functional. These children are paralyzed from the waist down. They often do not have bladder and bowel control either, but they still need surgical intervention to close the defect, to prevent infection, to cut away this dead, unfortunately necrotic, useless cauda equina, as well as close the defect and make sure that there's no chronic CSF leaks, etc. So the challenge with these cases is that the surgery is done on these children as neonates, so within the first few days of life. So fetal surgery improves motor outcomes, and we must be willing to manage them as quite a sick neonate, very small, potentially premature, potentially syndromic, for quite long surgery with a high risk of blood loss. So you have to be aware of any other congenital abnormalities. I think it's almost routine, and in my practice, if you have a midline issue like a spina bifida or like a vertebral abnormality, vertebral disc abnormality, you need to get a cardioechogram, because remember, the heart is in the midline, the trachea, the esophagus is in the midline. Your risk of a tracheoesophageal fistula or an AVSD or some thing like that is very high. So you must keep that in mind. These children get cold and they bleed, and the surgery is done in the prone position. So those are some important factors that one needs to take in consideration if one is anesthetizing a neonate with a meningomyelocele. So when we look at VP shunts and the placement of VP shunts, basically, the indication to place a VP shunt is, as we said, to divert CSF from the brain to the peritoneal cavity. And it's the primary treatment for managing hydrocephalus and preventing an accumulation of CSF. Basically, the catheter is inserted into the brain ventricle and then tunneled subcutaneously, as I said to you. And it's got a programmable valve in order to allow adjustments to CSF flow as needed. And you put a lot of length in so that as the child grows, the shunt still stays in the right place. From an anesthetic point of view, oftentimes it's not particularly challenging. It's a fairly quick procedure in the hands of a good surgeon and in the right center. It's often a small child, anywhere between 3 and 9 months of age, okay? I find intravenous access in these kids is always difficult, and I can't tell you why. I think it's because some of them have been premature. They've had multiple drips, multiple procedures, multiple anesthetics. So that's just one thing to keep in mind. And then remember, in the worst case scenarios where you have the children, unfortunately, who have been missed and who have got very, very large hydrocephalosis with large heads, their airway can become difficult because you've got a child who's sort of lying here, and then you've got this giant head like that. And so whenever you lie the child down, the head completely bends forward and obstructs the airway. So you need to just have a plan to bolster their shoulders and manage that. So In terms of other important considerations, we generally I do a gentle gas induction. I establish IV access. I then give some propofol. I give some opioid, and I then intubate. I always intubate these children. I never do it with an LMA. There is a small risk of a venous air embolism if the ventricle of the brain is breached, and you need to make sure that you maintain a good blood pressure so that the pressure between the venous system and the outside atmosphere remains so that blood exits the venous system rather than entrains air. These procedures are not particularly painful. Local anesthetic, intravenous paracetamol, and a short-acting opioid are more than enough. I do not use a muscle relaxant in these children. As I said, I intubate with propofol and a short-acting opioid. The reason being is that these children often have complicated neurological conditions. They may have neuromuscular disorders, mitochondrial disorders. They also are generally weak, malnourished, etc., and they've got an increased risk of postoperative apnea. So I just find that adding a muscle relaxant to that is just an unnecessary extra burden and risk. And as I said, intravenous paracetamol or acetaminophen, short-acting opioid and local anesthetic is more than enough analgesia. And they should probably get apnea monitoring according to your institution's guidelines in the postoperative period. They do need regular follow-ups because the shunt can become blocked, it can become infected, and children returning for VP shunt reinsertion for blocked shunts or infected shunts is a very, very common procedure that you will be doing. If we then move on and we look at endoscopic third ventriculostomy versus craniotomies for tumor resections, basically an endoscopic third ventriculostomy, as I said to you guys, is a procedure where there is an issue with the cerebral aqueduct causing obstruction to CSF flow. And so what is done is that a small endoscope is inserted into the brain through a small keyhole incision, and the stenosed aqueduct or whatever is obstructing that flow of CSF is identified. It is cauterized, it is cut open, etc., whatever specific surgical procedure may be needed. And essentially it opens then the floor of the third ventricle to allow for CSF flow, and it's indicated for obstructive hydrocephalus. It's done under GA with an endotracheal tube, and also basically exactly the same as for a VP shunt. They need even less analgesia because it is literally just a tiny 1 or 2 or 3 millimeter incision into the scalp and into the skull. And essentially it's the only sort of major risk is that they obviously use irrigation fluid to keep the ventricles open so that the surgeon can see what he's doing. And that can, if it's run in too quickly, if it's not the right temperature, can cause complications. But these procedures that I've been involved with are incredibly safe and they work incredibly well. When we're moving though onto craniotomies for tumor resections, we need to be then aware of the risks in especially posterior fossa surgery that require the prone position, the sitting position. We need to be aware of the risk of venous air embolism, the risk of seizures, the risk of neurovascular injuries and neurological injuries. We need to be aware of the risk of bleeding and of the additional monitoring and lines and invasive lines, etc., that we may need. And we need to be incredibly, incredibly vigilant when you're doing a craniotomy for tumor resection for a child. It's something that you really need to have a plan A and a plan B and a plan C and a plan D, even if you need for that child. So what are the other sort of common surgical things that we need to consider? As I've said, surgical techniques for epilepsy surgery can include focal reception or corpus calostomy. The most important thing here is that these cases are by far all done under total intravenous anesthesia. which preserves the intraoperative EEG monitoring so that they are able to determine which areas of the brain they're working in. Other anesthetic considerations that we need to be aware of is the total intravenous anesthesia is preferred, and you need to, as we spoke about with monitoring of MEPs and SEPs in scoliosis, you need to have a good communication and open communication with the neurophysiologist. When we talk about craniosynostosis, as I told you, it reshapes the skull by open or endoscopic techniques. By far the most common is open. And as you can see there, this can be associated with blood loss of 100% of that child's volume. So the entire child's blood volume can be lost in some of these surgeries. So bleeding is a huge, huge risk. You have to have as large bore IV access as possible. And just from a practical, anecdotal point of view, you can get a pink gel co in a neonate. I have done it. And you can get a green gel co in any child above 3 months of age, okay? So it can be done. Remember, you've got saphenous veins, you've got basilic veins, etc. You've got central veins. So you need to have as large bore IV access as possible. If you can't get a pink or a green gel co in, you need to have at least 2 or 3 blue gel cos in the child, as well as a central line. It's critical because you need to have, in my opinion, 2 anesthetists or a very, very qualified anesthetic assistant to help you just with syringing in blood, managing the cell saver, managing the fluid status, etc. So as I said, they're a lot of fun. I really enjoy doing them. They're incredibly rewarding. They're exciting, but they're also exhausting. And then just to talk a little bit seriously, hopefully you never have to see one of these, and I haven't done one of these in my career, thankfully. A decompressive craniectomy in a child. This is when a child has got a severe neurological injury, most commonly from a trauma where intracranial pressure is catastrophically high, and the child is coning with evidence of a bradycardia, hypotension, persistent seizures, raised intracranial pressure, and a low GCS where the patient is having a Cushing reflex. So in an anesthetic, the most important anesthetic feature of this is that you need to maintain hemodynamic stability in a child who doesn't want to be hemodynamically stable, who's having a Cushing reflex. So it can be incredibly challenging. You need to lower the blood pressure gently so that you lower the intracranial pressure while they are operating. You can do that by blowing off CO2 to a low level shortly for a period of time, just to temporarily lower the intracranial pressure. But at the same time, you need to support the mean arterial pressure so that they have an adequate cerebral blood flow and cerebral perfusion pressure. And you need to give mannitol and other osmotically active agents. And then we need to monitor them with an arterial line, with a central line. And we will then need to place, the surgeons will then need to place an intracranial pressure monitoring device. So hopefully you never have to be part of one of these scenarios though. So as we look here, there are some specific intraoperative complications in pediatric neuroanesthesia that we need to be aware of. The first one is something I've mentioned a few times already, venous air embolism. And it's a significant risk in pediatric patients because their central venous pressure is much lower than an adult. And so the risk of entraining air from the atmosphere into a damaged cerebral vein or one of the cerebral sinuses is a significant risk, especially in the sitting position. Although I must be honest, thankfully, very little surgery is done in the full sitting position these days. So the risk is somewhat lower. But it's something we need to be aware of, something that you need to be able to manage. So the signs of a venous air embolism is, as we would expect, you've entrained atmospheric air into the circulation, and that can cause a catastrophic airlock, or it can cause a embolic effect. So you get sudden hypotension, desaturation, and a sudden significant drop in end-tidal CO2. Detection methods involve the use of a precordial Doppler. I don't know anyone who uses that. And to be honest, these days, the use of a transesophageal echo probe is by far the most common and most sensitive and best tool to use. And I'm sure those of you that have done cardiac surgery or anything like that, where you have had a TE probe in, I'm sure you've seen that even when you inject sort of, a normal 10 mils of saline or morphine or whatever it might be through a central line, even though you've made sure that you've got rid of all the bubbles, as you push, whatever air is in the liquid gets agitated, and you see what looks like a little snowstorm of tiny little bubbles going through the right atrium. And so if you've got a TE probe in, you'll be able to detect a very large entrainment of air. How do you manage it? Well, it is an emergency, okay? It's something that you need to declare to the team. And firstly, the area that is being operated on must be covered. It must be flooded with saline and with wet gauze and swabs. You should ideally get the patient in a head down position so that you can increase the venous pressure so that no more air is entrained. And there is a theoretical, described in the books, method whereby you put the patient head down in the left lateral position so that the right atrium is the most superior part of the heart. And your hope is that if you have a central line, that the tip is sitting just in the right atrium like that, okay? You can aspirate the air. I've spoken to very, very senior, older anaesthetists. They say it's, you hope and try. I've never had a significant venous air embolism whereby I've needed to try, but it's worth giving it a try, but whether it'll work or not, the jury is very much not undecided, should I say. You then also obviously need supportive care. You need to ventilate them adequately. You need to support their cardiovascular system. And then you need to prevent more air from being entrained. You then also need to be able to handle increased intracranial pressure. We've been through that in our physiology lecture, but just remember there are multiple ways by which you as an anaesthetist can influence intracranial pressure. The quickest and most easily titratable method is to control the PaCO2, so you can hyperventilate or hypoventilate. Remember, you should never go to extremes, because especially as you blow off CO2, as you lower the PaCO2, you get progressively more and more cerebral vasoconstriction. Now, in adults, in elderly patients, they can get neurological deficits from this, but it can happen in children as well. So I never go below an end-tidal CO2 of 30 millimeters of mercury, unless I have an acute problem where they're coning, where they're having a Cushing reflex, and I'm trying to sort of fix that problem quickly. And then remember, your use of propofol, even your use will drop intracranial pressure. Remember, if you're using volatiles, they must not be at a MAC of greater than 1, because that can increase cerebral blood flow and increase intracranial pressure. And then you need to know the dose of mannitol and hypertonic saline. The dose of mannitol is 0.5 to 1 ml per kilogram as a bolus. In children, I always start slow. So I go in infants, I use 0.25 mils per kilogram as a bolus. And then I repeat that to a total of 0.5 mils. And then the surgeon and I have a discussion about how the brain is looking and feeling and how the vital signs are doing. And so just remember that if you use hypertonic saline or if you use mannitol, you are going to get an osmotic diuresis. And in children, you can get a rapid depletion of their intravascular volume, okay? Because they pee out a very large volume of urine in a very quick space of time. So please make sure you keep up with their fluids. And then remember the other issue, which I've been over, but just to mention again, because it can be so catastrophic and scary, is blood loss and management of that bleeding during craniosynostosis surgery. So there we're going to be looking at things like use of tranexamic acid, maybe at definitely the use of a cell saver, the use of colloid products, the use of FFP or freeze-dried plasma, the use of all the blood components, the use of tranexamic acid and all of those things, keeping the child warm, keeping the blood pressure at a normal level, but not too high. So a safe form of hypotensive anesthesia. And all of those critical things, maintaining a normal calcium to aid clotting, etc. If we look at some post-operative complications and the management of those, a few of them, just to go through, is something, number one, called posterior fossa syndrome. Now, what posterior fossa syndrome is basically in about 15 to 30, or even, it depends on which text you use, in a fairly significant percentage, shall I say, 30%, 15% is a lot, excuse me. Basically what happens is that the child ends up getting ataxia, emotional disturbances, fluctuations in their level of consciousness. They may get visual deficits, etc. And it's basically because you've had a very large tumor in the posterior fossa that's been hogging all the blood flow and compressing the other structures, probably with some obstructive hydrocephalus, okay? So now you remove this big tumor, you fix the obstructive hydrocephalus, and now you get a sudden hyperperfusion, an over blood supply of the posterior fossa, of the brainstem, etc., and of the cerebellum. And so they get cerebellar dysfunction, they get brainstem issues, they get cardiovascular issues, emotional issues, etc. It generally settles, but it can last for a significant period of time after posterior fossa surgery. The next issue, as I said, very, very common, VP shunt malfunction. It blocks or it becomes infected. And this happens about 10% a year in the first year. Post-craniotomy seizures, number 3, is something we need to be aware of, okay? And I have a very low threshold, along with the excellent pediatric neurosurgeon with whom I work. We have a very low threshold of giving antiepileptics. My preference is Epilim, so sodium valproate, at a loading dose of 15 milligrams per kilogram. However, Keppra is a very, very good and safe alternative. I do not use phenytoin in children, but seizure prophylaxis is key because a post-op seizure can be catastrophic. And then we need to be aware of cranial nerve injuries, spinal cord injuries, brainstem injuries, etc., and neurological deficits that arise from those issues. So there really can be multiple complications. Some are expected, some are transient, but some can be permanent and catastrophic. So just to go over some anesthetic specific issues, we need to be aware of emergence delirium in children. It's something that's not isolated to neurosurgical issues or conditions. And essentially it affects, I always find it quite funny when you have an incidence of, in some studies I read, 10 to 90%. This reference here says 10 to 50%. I mean, it means they have no real idea of the incidence. In my practice, it is not that common. It is probably closer to 5%. And there's specific children that have it, and we're going to do a full talk on emergence delirium, but it's just something to keep in mind. Postoperative nausea and vomiting is a huge issue. They've got raised intracranial pressure, they've got neurological issues, they've got brain bleeds, they're on chemotherapy potentially, so they've got a lot of reasons to have PONV, and you really don't want them to be retching and straining and coughing and all of that. So they must get multiple levels of prophylaxis. I use a steroid, dexamethasone, I use ondansetron, I will use droperidol if needed, I will use metoclopramide if needed, and I will even use an antihistamine if needed. And then remember that postoperative sedation and analgesia needs to be balanced with the need for rapid neurological assessment. So that is why I like to use desflurane as a volatile in particular if I'm going to use a volatile, because the wake up is rapid and clear-headed, and they are able to engage and give you a clear neurological assessment. But obviously by far, and as I've explained in many of these talks for many reasons, obviously the use of a propofol-based total intravenous anesthetic is ideal, especially to allow them to be adequately sedated, with a little bit of maybe dexmedetomidine in the postoperative period, but we need to be able to rapidly assess their neurological function. And then we must minimize the amount of opioids that we give to all patients, but definitely to children. in the neurosurgical unit. We do not want them to have apnea. We do not want them to have airway obstruction. They may already have a reduced level of consciousness and GCS. They may already have issues protecting their own airway, especially if it is a cerebral palsy or if there's been a cranial nerve palsy or a brainstem issue. And we need to be giving them local anesthetic, paracetamol. Once there's no more issues or concerns with bleeding, the use of non-steroidals is perfect. But limit the opioids that you use. And as I said, you don't want them to retain carbon dioxide and have an increase in intracranial pressure. That can be catastrophic and has been fatal in certain circumstances. And that's why Precedex, the use of dexmedetomidine, is my favorite and I think is the safest way of giving adequate sedation, minimizing opioids, but also providing a safe sedation. So when we look at my specific approach to the preoperative assessment of these children, the first thing that you need to do is you need to obviously assess their neurological status. So you need to assess what are they coming for, what is the surgical issue, and we'll talk about it more in our lecture on pediatric oncology, but I always talk about the 4 M's when we look at the effects of a brain tumor or any other tumor. So number 1 is M for mass. What is the mass effect? Okay, so is there midline shift? Is there raised intracranial pressure, etc.? Number 2 is metabolic. So what are the metabolic side effects? So is there SIADH? Is there diabetes insipidus? Is there cerebral salt wasting syndrome or Cushing's disease or anything like that? Then there is the medication effects, and that is the effects of any chemotherapy, whether they are on any radiation, and any intrathecal chemotherapy, excuse me, that's the word just blanked there for a second. And then the last effect is whether there are any metastases. Now, often in adults, brain tumors are METs, but in children, remember, you're very unlikely to find METs because brain tumors are primary tumors in children. We need to evaluate, are there signs clinically of raised intracranial pressure? We have to review their imaging and look at the tumor, look at the CSF, look at the hydrocephalus. Is there evidence of AV malformations, of bleeds, of blockages, etc. And then we need to optimize any pre-existing comorbidities. And importantly, we need to ensure that they are seizure-free as much as possible before they come to theatre, because that can be very difficult to control. In terms of intraoperative anesthetic strategies, what I do in these children, it all generally depends on what they're coming for. You know, as I said, I'm not opposed to a slow, controlled inhalational induction with oxygen and sevoflurane at no more than about 4 to 5% briefly. However, the use of local anesthetic EMLA cream, or my wonderful pediatric colleagues who know who they are, thank you ladies in particular, who will put up a drip for me, and then I will do a propofol induction as normal. I will use a muscle relaxant to facilitate intubation and ventilation if they are not monitoring motor evoked potentials. I will use multimodal analgesia. Ketamine is controversial in terms of its role on intracranial pressure. I would just avoid it in general. Remember that intracranial surgeries, posterior fossa surgeries, VP shunts, these are not particularly painful procedures. The only procedure that is very, very painful is craniosynostosis surgery. And in those children, we will definitely give them ketamine and everything else we can. I maintain most of the anesthetics with a combination of propofol or volatile, as well as dexmedetomidine, controlled ventilation. I would do standard ASA monitoring plus invasive monitoring as dictated by the surgery, Definitely any major intracranial procedure, you need a minimum of 2 peripheral IV lines, a central line, and an arterial line. Then advanced monitoring, as we've spoken about, may be motor evoked potentials, sensory evoked potentials. You may do depth of anesthesia monitoring using entropy or BIS if appropriate. You may also do cerebral oxygen monitoring with the use of near-infrared spectroscopy. And then, as I spoke to you guys in the scoliosis talk, you need to be aware that you need to facilitate neuromonitoring, and that means avoiding volatiles, avoiding muscle relaxants, and not giving any large boluses or pushes of any drugs, and having close communication with the neurophysiologist, using a propofol TCI, and keeping the physiological status of the child as close to normal as possible. We also need to be aware of the issues of positioning, okay? So, in particular, the prone position. We spoke about the prone position in the scoliosis lecture. I encourage you to watch that if you haven't already. But the prone position, you need to be worried about pressure sores. You need to be worried particularly about the eyes and postoperative visual loss, as well as how to ventilate the child to maintain normal intrathoracic pressure. Remember, if you raise intrathoracic pressure, by definition, you impair venous drainage from the jugular veins, and therefore you increase intracranial pressure. You need to be aware of having a neutral airway and not a hyperflexed neck or a hyperextended neck that can compress various structures and again lead to cerebral edema. In terms of the sitting position, the biggest advantage is that there is less blood loss because you have the effects of gravity draining blood away from the lesion. The lesion sits in its most anatomical position and is often easier to access from a surgical point of view. However, the issues of access to the child, issues of the airway, issues of the risk of a venous air embolism means that I don't work with any surgeons who still use the sitting position. The lateral position, however, is very commonly used, okay, especially when you've got unilateral tumors, etc. And again, the lateral position, you need to be aware of pressure issues. You need to be aware of the risk of VQ mismatching in terms of the perfusion and ventilation to the lungs. And you need to just have a good ventilatory strategy, a low PEEP to facilitate venous drainage so that you don't raise intracranial pressure. We have to maintain good temperature control. And guys, we don't make these patients cold, please, okay? Active cooling has never been associated intraoperatively with a better outcome. I'll say that again. Active cooling of patients intraoperatively has never been associated with a better neurological outcomes in neuroanesthesia. So what we do is we do not actively warm the patient to above 37 degrees, but we do not allow the patient's temperature to drop below 35.5 degrees either, okay? And the big issue, just from a practical point of view, guys, where you will pull your hair out, I promise, as I've said to you, whether it's in the remote side anesthesia suite, you've in a neuro theater, you've got the surgeon, you've got a microscope, you may have a robot in the modern world, you've got a perfusionist for the cell saver, you've potentially got a neurophysiologist, you've got the guidance people, the navigation people, and all of that. You have to have long IV lines, but they have to be secure and they have to have backups, because there's absolutely nothing more nightmarish than your one good drip you lose, and now you're digging under drapes and feeling for feet, and it's a disaster because you put in a central line and it was working great, but now the child's head is a bit flexed and your central line is kinked, so it works well for infusions with the pumps, but as a bolus, remember guys, a central line is not a resuscitative tool at all. I'll say that again. A central line is not there to fluid resuscitate people, okay? Peripheral lines and high cap lines are for that. So just ensure that you've please got access to your lines, okay? In terms of the post-operative care and management of these patients, we need to have obviously a multimodal analgesic approach. So with minimization of long-acting opioids. So as I said, I use local anesthetic. I use local wound infiltration. I use non-steroidal anti-inflammatories once there's no bleeding risk or if there's no kidney issues. I use dexmedetomidine infusions. I hardly ever give long-acting opioids, okay? In terms of monitoring the intracranial pressure, every institution has their own protocols, but the neuro-ICU should be well equipped to manage intracranial pressure monitoring devices. We need to do early and thorough neurological assessments, and we need to do them frequently, looking at things like pupil size, motor function, responsiveness, etc. And we need to remember we need to have access to rapid imaging if there's any deterioration. Oftentimes, these children are taken straight from theatre for imaging in the MRI suite and then to ICU. And in some units, there is an imaging, a CT scanner or an MRI suite attached to the neurosurgical theatre, but you have to have access to rapid, quick imaging. And then we do need to just think about some ERAS protocols. ERAS, remember guys, stands for Enhanced Recovery After Surgery. And there are specific ERAS protocols for neurosurgical procedures. But essentially, they're looking at optimizing nutrition, optimizing analgesia, making sure there's no seizures, making sure that there's no nausea and vomiting, and that you mobilize and discharge the patients as soon as possible. So please go have a look at your local ERAS guidelines, or go and search the ERAS guidelines online. Some age-specific issues, some physiological issues, and some developmental issues. Remember that some of these procedures, as I said to you before, guys, are done on neonates. So you can do a VP shunt in a neonate. I've done a lot of myelomeningocele, spina bifidus, etc. And I've done, unfortunately, Budd-Chiari malformations or AV malformations, etc. in neonates. So you need to be comfortable, not just with neuroanesthesia, not just with neuroanesthesia in a neonate, but with neonatal physiology and anesthesia as well. And we're going to talk all about neonates next week. All right. So we'll have more about that. You need to be aware of the developmental issues, of the concerns with anesthesia and the developing brain. Just remember, I did a Dr. Tristan Explains to the Public where I summarized that literature for parents and for the greater public. But you need to be aware of the risks of prematurity, the risks of surgery, of brain tumors, and all those conditions. You need to be very sensitive to the psychological needs of older children and toddlers. You need to be sensitive to their psychosocial development, and you need to have strategies to manage their anxiety and manage their risk of PTSD. And then you need to have customized anesthetic plans. And so, you know, just to tell some anecdotal stories vaguely so as not to obviously disclose any identities, I'm very fortunate to do an MRI list, as most of you know, and I've really met some incredible parents and patients and families and kids, you know. And, you know, one of them, for example, was a child who'd had a terrible experience with an anesthetic for a scan overseas. Unfortunately, he had a brain tumor. He needed another MRI, and the child needed surgery, etc. And I ended up being the anaesthetist for many things, for a port and for all of the MRIs. And we've developed a rapport because it's me who's there all the time. We get to have a great sort of relationship, and there's multiple kids like that, you know, bless them, they're wonderful. And, you know, normally in South Africa, the medical aid or medical insurance, as you would know it sometimes, doesn't pay for anesthesia. They won't pay for my bill after the age of 8. But some of these children that I've worked with have got significant post-traumatic stress disorder because they've been in and out of hospital, surgery, theatre, biopsies, chemo, MRIs, etc., radiology procedures. So we then motivate to continue doing general anesthesia or sedation for the MRI. So you need to just keep in mind the psychological consequences of these conditions. And then as we're sort of moving towards a close, we need to have ethical and psychosocial considerations. Again, Informed consent is an issue, and you need to make sure that, if the child is old enough to understand, and in South Africa, the legality is to assent, whereby they give a sort of notice that they understand their surgery. If they have that sort of emotional and intellectual capability, you need to try and get some form of informed consent from them. And remember, if you look at the Health Professions Council and other ethical guidelines, the Medical Protection Society guidelines surrounding consent, and we'll do a full lecture on consent at some stage, is the more serious the complications and side effects and the risk, even if they're very rare, those need to be disclosed, okay? So you need to address issues that, with any surgery, neurosurgery, that there could be significant side effects. When we're looking specifically at traumatic brain injury, unfortunately in South Africa, and I'm sure worldwide, you need to be very, very vigilant and ask questions about non-accidental injury. And we have to offer psychological and psychosocial and sometimes even routes for financial support and social worker support for families. If we focus on the posterior fossa for a few minutes, the posterior fossa, as I said, is a very common site of medulloblastomas, and for tumors in sort of all of children. And so there are specific consequences and side effects. And this specifically is cranial nerve lesions present early, and cerebellar signs such as ataxia, nystagmus, seizures as well. Common cases, as we say, involve medulloblastoma, but it can be Budd-Chiari malformations, and it can be AV malformations as well. Depending on the cause, I'm going to just focus mainly on medulloblastoma resection because that is the most common, and the goal here is almost 100% surgical resection as you can get safely, and that's why we may do staged procedures, we may do multiple procedures. And the reason being is that these tumors grow so rapidly, and the small child under the age of about 2 to 3 years of age, depending on where you are in the world, radiation to the brainstem, to the posterior fossa, can have catastrophic side effects and consequences, and is generally contraindicated until they're older. So you need to get surgically as much of the tumor out as you can as possible. And you need to do this while maintaining cerebral perfusion pressure, reducing ICP, and there are sensitive structures that the surgeon is working there. You have to have a good relationship. You have to have an open chat. Stop. I've just got a Brady. Stop. I've got an unexplained tachy. My BP's spiking. My BP's tanking. Oh, look, suction. I'm hearing. Okay, I need to, hey, what's happening? Yeah, listen, we've got a bit of a brisk bleed. Okay, I'm giving XYZ. I've got fluid. I've got blood. I've got my cell saver, etc. So it needs to be a very dynamic team sort of approach to this to keep them safe. As I said, the anesthetic challenges is the position. So most of these are now done in the prone position. So that's all the concerns of the prone position as we've spoken about. However, you need to be aware of the sitting position because it can still be used and you don't want to be caught out. Venous air embolism and how to manage it, as we've spoken about, you need to be aware of. You also need to be aware of all the other issues with the prone position. And you also need to be aware of the brain stem structures there. So the cardiac accelerator center, the respiratory centers of the brain, etc., of the brainstem are in that area. So you need to be highly, highly sensitive and have a high index of suspicion that these children might need hemodynamic support for post-operative period until their neurological function recovers, and they probably will need, in all likelihood, post-operative ventilation. It would be a very brave / foolish person who would extubate a posterior fossa surgery. And then clinically, these surgeries, if done well, as we had the success story with myself and the surgeon that I have the pleasure of working with, it was a long process. The child was in hospital for months, and there were major complications, but the child is doing well. And so if you are meticulous, if you push the limit as far as you can safely, and that's why I say, not to sound arrogant, but I, and as qualified professor neurosurgeon, can push that boundary pretty far and get a huge amount of debulking and good work done. Say stop, let's close, let's recover, let's catch up, etc. And so you need to have, this is not this sort of fly by night willy-nilly thing. You need to have a very, very good multidisciplinary team that does this often. Positioning, as I've said, the prone position is the most common. The sitting position can be done, but the risk of venous air embolism is a problem. Lateral, or the so-called park bench position, just to show you what that might be, is it's essentially, if you imagine you're lying laterally, but you've got an arm like this and like this, an arm here, as if I'm lying on a park bench, and the head sort of tilts forward like that, and that allows you to often get to lateral posterior fossa. Much less complications from that position, but you still need to be aware of it. And then universally, you need to have a very secure airway, okay? You need to have hemodynamic monitoring. You need to have ability to respond to rapid bleeding and rapid hemodynamic changes. And you need to make sure that you are facilitating neuromonitoring potentially, and that you are preventing seizures and all of those things. So again, it's something whereby you must pay meticulous attention. Monitoring for venous air embolism, I'm not going to go into it in detail again, but remember I said the best monitor is a transesophageal echo probe. And to be very fair, I know some of you, I don't know, maybe I hope I'm not being too sort of blasé, but if you're in a hospital that is doing posterior fossa surgery in children with big medulloblastomas, you can very easily justify the need for a pediatric transesophageal echo probe. Really, you can, because I mean, it's just in this modern world, I think it's just such a vital monitor to have. So remember, you can do transcranial Doppler, you can do precordial Doppler, you can do end-tidal nitrogen monitoring, you can do end-tidal CO2, but transesophageal echo is by far the most sensitive and monitor to use. You must maintain a vigilant eye on end-tidal CO2. Any sudden change in end-tidal CO2 in any patient, but especially in a child, especially in a neurosurgical procedure, is something that must be spoken up out loud quickly and must be actioned upon quickly, okay? Monitor unexplained tachycardias, changes in blood pressure, etc. Rapid management, as I've said, you need to flood the area, you need to get the head below the center of gravity, and if you can, visualize the air bubble on the TE probe. You can try and aspirate it, and in a worst case scenario, you will do chest compressions to try and break up that bubble so that you get dozens of small emboli that go peripherally rather than one or two large emboli that completely cause an airlock and obstruct blood flow. You must, though, prevention is better than cure, and that's why, as I said, practically, I don't know of any surgeons that I work with that use a sitting position still. When we speak about neuromonitoring, there are multiple forms of neuromonitoring that can be done during posterior fossa surgery. Motor evoked potentials, which we spoke about, remember, is a top-down approach whereby the cortical area is stimulated and the response is felt in the muscle motor pathways. Somatosensory evoked potentials is the opposite, whereby the muscle or peripheral nerves or wherever its spinal nerves are stimulated. You then get specific brainstem monitoring. The first one is brainstem auditory evoked potentials, which is, as it says, it is auditory. So a stimulus is applied to the ear and the response is measured in the brainstem. And then we can do direct cranial nerve monitoring. Remember, from a practical point of view, that if you are going to be doing this neuromonitoring, you have to run a total intravenous anesthetic, TCI, with propofol and no muscle relaxant. You need to manage intracranial pressure by elevating the head, as we've said, making sure that you have adequate venous drainage of the jugular veins, and then use transient periods of hyperventilation only if needed, and only for a very short period of time if there is a high risk of herniation. You can give mannitol or hypertonic saline. As I said, the dose of mannitol is about 0.5 to 1 ml per kilogram, and the dose of hypertonic saline that I use is 3 to 5 ml of hypertonic saline per kilogram. Give it slowly, and remember that it will affect your hemodynamic values. It will draw fluid into the intravascular space, and then the child will form large volumes of urine. You must set yourself hemodynamic goals that are action goals, So what I describe is, if you talk sort of an action target is, okay, so my mean arterial pressure must go no lower than 55. Okay, if it hits 60, that's pre-target, but it's drifting down. What is my first action? Okay, I'm going to deepen the level of anesthesia. Maybe I'm going to administer a small dose of a vasopressor. Maybe I look at the swing on my A-line, or my pulse pressure variation, or my stroke volume variation, or I look on the transesophageal echo probe and I see that the heart looks very empty. I need to give fluids, etc. So you need to be responsive, and you need to have a plan. As I said, step 1, 2, 3, 4, 5. Okay, if the neuromonitoring signal is lost, you're going to say, okay, everybody stop. Has my anesthetic changed? No, nothing's changed. The blood pressure's still good. The temperature's not so bad. Okay, no, there's a surgical issue there. I'm pretty confident. Or, okay, guys, just stop. We've bled a bit. My HB's just come back from the gas at 7.6, and the pH is 7, is a bit acidotic. My base excess is -6. Is bleeding currently under control? Yes, Tristan, it is. Dr. Tristan, it is. Great. Let's just stop. Take a breather. Let me catch up. Let's warm the kitty up. Okay, magically, all the signals come back from the monitoring. Okay, guys. So it's a dynamic process, and you have to manage blood loss, and you have to make sure that you have a good relationship and a good team that anticipates steps and is not always reactive. I say in any anesthesia, but in high stakes anesthesia, you can't be reactive. You have to be anticipatory, okay? You have to know, and that's something that unfortunately only experience or a very experienced person can teach you, is what's coming next. I already am standing up and preparing for A, B, C, and D. So, okay, the surgeon asks for mannitol. I put my mannitol and my Buretrol. I start running it. What do I know is immediately going to happen? I'm going to get a spike of blood pressure. Okay, so what do? I maybe just vasodilate them slightly to accumulate that. Okay, but I know now they're going to start peeing like a racehorse. So what fluid have I chosen to replace it with? Okay, I'm going to replace it with a colloid or some fresh frozen plasma or some blood, whatever you choose. Even clear fluid. I'm not going to dictate that right now, okay? But I'm anticipating one step after another what is sort of coming, so that you are proactive and you're ahead of the curve and you're not catching up all the time, okay? And then please make sure that ET tube is strapped securely. They're in Murphy head rings. They're in Mayfield clamps. They're in a million things. And you don't want to lose an airway, guys. It can be an absolute catastrophe. Post-operatively, when we're talking about the posterior fossa, as I've said to you, we need to be concerned about the posterior fossa syndrome. Now, that is can occur in up to 30% of these cases. And it's where children are mute, they have ataxia, emotional lability, and essentially the sort of treatment for it is supportive and rehabilitative with occupational therapy, physiotherapy, speech therapy, etc. And as I said, it seems to be an issue with a sudden hyperperfusion of blood and an overperfusion of blood causing edema in the posterior fossa and the brainstem and the cerebellum, because there's now no longer this tumor and this hydrocephalus stopping blood flow. We need to evaluate for cranial nerve deficits. Most of them are transient, thankfully, but some may be permanent. And we need to be especially aware of the swallowing reflex and the gag reflex. And so that is why speech therapy and swallowing assessments are critical in the postoperative period here. Pain management, as I've said, please avoid long-acting opioids, and please don't just sedate these kids willy-nilly. It's really not necessary and it can be damaging. We need to monitor them neurologically, their pupil size, their motor function, their GCS. We need to monitor the risks of seizures. And then we must have a high index of suspicion in any surgery that there could be hydrocephalus postoperatively and a raised intracranial pressure. So what does that mean? They need to have a standard protocol according to the surgeon and the unit on when they get their CT scan post-op, day 1, 2, or 3, or if they get multiple, if they get a cranial ultrasound or MRIs, etc. There must be a protocol for monitoring and scanning and imaging in the postoperative period. So the key takeaways, you have to be aware of the positioning, okay, in posterior fossa surgery, guys. You need to be familiar with all of these positions, okay? You need to have a monitoring strategy for venous air embolism. And as I say, I strongly encourage the use of transesophageal echo. You need to know the essentials of neuromonitoring and how to give a safe anesthetic that facilitates neuromonitoring. You need to know how to manage intracranial pressure and hemodynamic stability targets and goals. And it has to be part of a team that does this often, that works together. And as I say, we can all be anticipatory, we can take steps forward together, and we should not be reactionary. And the sign of a good anaesthetist and a good surgeon and a good team in theatre especially is a team that is anticipatory, that is not reactionary, and that works really well together. So we do have to talk about staged procedures, as I spoke to you in the anecdotal story of just a brilliant case that I could be involved in for months and months, but a tough one for everybody, especially the family and obviously the brave child. But the rationale for staging posterior fossa surgery is that when you have got large tumors that are encasing the brain stem, cerebellum, the vertebral arteries, the basilar arteries, the cerebellar arteries, we know that these kids can't get targeted radiation there. The effects are just catastrophic on the developing brain. We know that chemotherapy doesn't work in that area, especially for medulloblastomas. So the only hope is surgical. So as we said, you resect as much as possible and you monitor strictly blood loss, temperature, and the hemodynamic consequences of getting close to the brainstem and the cerebellum. So do you get unexplained? Most commonly, it is unexplained severe tachycardias, okay? Now in kids, that's not always too much of a problem because you like the tachy for the rate dependentness, as we've spoken about before. Excuse me. That's ice, I'm so sorry. No, but the problem is that you don't want them to sit at a heart rate of 175 either. So, but they can get very low Brady's, low blood pressures, etc. So you need to, as a team, have a chat and say, okay, this is the surgical target. What can I do as the anaesthetist to facilitate that? And what are our hard outs? When do we say, okay, we're cold, we're acidotic, or it's been 12 hours or whatever, we need to stop for now. Okay. So we then need to facilitate the anesthetic. We need to make sure that there is absolutely no neurotoxic or any anesthetic morbidity or issues. And we have to manage blood loss meticulously. And as I've said, once we've transfused, you can sort of decide, our general rule is once we hit 2 adult units of blood and 2 adult units of FFP, we stop. And once we're on anything more than about 0.1 to 0.2 mics per kilogram per minute of adrenaline or noradrenaline, thank goodness we hardly ever need that. But those are sort of our hard outs. And then we chat, we talk to each other. Tristan, yes, how's it going? No, I'm happy. He's looking really good. Look at the blood gas. So every time I do a blood gas, I read it out, whether it's good or bad, okay? This is not the time for ego. This is, as Tina Turner said, we don't need another hero, sort of thing. And it's true. What you need is honesty, and you need to critically appraise, where are we, how are we going? And that is how me and myself and the surgeon that I work with and the team, that is how we managed to get 12 hours 2 weeks in a row. So we, on a Saturday we did 12 hours and we got 95% of that tumor. Okay, so it can be done, but you need to have a risk benefit analysis, and again, the teamwork is so absolutely critical. What are the challenges and complications? Well, they end up having multiple anesthetics for a prolonged period of time. The infection risk is something that is an issue, and that is something that did unfortunately come into effect in the story that I told you, because the patient is in the hospital for a long time and they pick up nosocomial infections. Posterior fossa syndrome and all of those neurological complications, the risk is there every single time. So if you have 2 surgeries, the risk doubles essentially, Postoperative recovery and rehab can be very long, but children recover well, okay? And as I said, the case that I was, really fortunate enough to be involved with, good outcome. Takes time, but children are resilient, and God is good, and so you can really have great outcomes. And however, I'm not going to lie, it is complex, it's challenging, but it really is something that we need to be comfortable with, and something that we need to sort of be willing to be part of, because it really can improve outcomes. So as we near the end, guys, I just want to run through a few more things. We need to also consider in general surrounding pediatric neuroanesthesia that sometimes you might need intraoperative monitoring. So especially the use of intraoperative MRI or CT scanning. So there's the MRI risks that we've spoken about before, the radiation risks, as well as moving the patient potentially, okay? We need to be aware of the neurodevelopmental impact of posterior fossa surgery, but of all neurosurgery. We have to be meticulous about infection. It can be catastrophic, okay? So antibiotic prophylaxis, cefazolin, 30 milligrams per kilogram. I give it before induction, or at induction, before skin incision. I then also give it every 4 hours, and then we put the children on cefotaxime or ceftazidime postoperatively, or ceftriaxone. We need to make sure that none of the drugs we give are neurotoxic, and we also need to make sure that we maintain good hemodynamic stability to facilitate safe neuroanesthesia. And a good neuroanesthetist, a good pediatric anesthetist, a good team, a good multidisciplinary team can really improve surgical outcome in these cases. I really believe it. Oftentimes, you'll have the debate really of volatile versus TCI, this drug versus that, Sugamidex versus Sigmine. A lot of the time you'll see we do these studies and there's no real, clinical or significant difference, but a solid neuroanesthesia team led by a pediatric neuroanesthetist, somebody who's got an interest, a passion, but also, like I said, a mind that anticipates, that has done lots of these, you really can facilitate excellent patient outcomes. And you can make yourself a center and your hospital a center where you can bring these patients for excellent care. We also need to be aware of the psychosocial impacts of everything that we do, guys. It's something that I'm really trying to add as a slide in all of these talks, the PTSD risk, the effects on the family unit, the family structure. Mom often stays with the child at home in the hospital for months. Dad is home with the other kids. Is there other family or friends for support? Informed consent. Remember, every single time that child goes to theatre, no matter how many times you've taken them to theatre, you start the informed consent journey from the beginning. And it's something that I will admit sometimes we all get blasé with, but we really need to not, and it's something that I'm very conscious about now, because remember, every time you take that child to theatre, God forbid something can go wrong, and you need to make sure that everyone is aware of the risk. Please make sure you have a multidisciplinary team. So the team that I have, as I say, consists of the same peds anaesthetist, me, the same surgeon, okay, the same generally surgical assistant, the same nursing team, start a team in theatre, so the same scrub nurse who always does neuro, the same floor nurse. I generally get one of two of the best anesthetic nurses, and we all know our role and we know what to do, and we move seamlessly, sometimes without even using words, and it's brilliant. And the more you do that, we then have an intensivist, we have a pediatrician, we have a peds cardiologist, a neurologist as we need, infection control experts as we need, okay? Please maintain your ethics and be vigilant to treat all patients ethically, even if they've got severe neurological compromise or severely limited neurological sort of function or intellect or understanding. And I really think that these patients benefit most from a comprehensive pediatric neuroanesthesia care team and units and hospital, etc. So guys, in conclusion, we've kind of gone through today tailored approaches in pediatric neuroanesthesia. And essentially, as I've said to you guys, your strategies, they need to be tailored. It all depends on the case. A VP shunt is a very different entity to a posterior fossa surgery, to a craniosynostosis, to a scoliosis. So, you need to understand the child, the condition, you need to understand the surgeon, you need to understand the procedure and the requirements from both a hemodynamic stability, both from a neurological safety point of view, as well as from a neuromonitoring point of view. Remember, you need to be aware of the need and the possibility for staged procedures, and how we need to maintain safety and not push surgical procedures too far and end up harming or hurting the child. We need to have excellent monitoring, both hemodynamic and neuromonitoring, as well as monitoring for venous air embolism. So in my opinion, a transesophageal echo probe is almost indispensable in these cases. We need to work in a multidisciplinary team where everybody's role is defined, and where ideally, as I work, we all do this together all the time, quite often, where the regularity means that we work really well as a team. And as I say, critically, we anticipate, we don't react. And just there is something to be said, really about the resilience of children and the absolutely mind-blowing, miraculous, incredible ability of the pediatric brain to heal itself and to recover and to respond and those sort of things. It's so rewarding, and I'm sorry, I'm going to sound like Mother Teresa now, but everything I do is rewarding. But really, the outcomes of kids, who have 24 hours of theatre time and have 3 months in ICU and trachees and who have seizures and who have big tumors and all of those things, and to really see that they can do so well, and that as a team we really can make a difference because we manage them properly, we work together, and we really focus on the patient, and we do what we know is best for that patient. I love the peds neuroanesthesia, I really do. A shout out to the team that I work with. I obviously don't want to give details because I never want to give away details of patients, I never ever, but they know who they are, and it's a privilege to work with you all, and I'm so proud of the work that we do. I hope you guys have enjoyed this lecture. Remember, please, to go to Patreon to subscribe, and there will be show notes. Once you do that, there will be an Ask Me Anything section, and I will send you all of the resources and more. So that's it for now from Dr. Tristan, for Dr. Tristan Anesthesia Tutorials. Have a wonderful evening, and I will see you tomorrow with our next lecture. Thanks so much, guys. Remember, patreon.com/Dr. Tristan Anesthesia Tutorials. Have a wonderful evening.